Yes, great. I'm Nazleen Bharmal. This is Ndidi. We're just so excited to be able to talk to you about advancing health equity at Stanford Medicine. Just for context, I have been here for 2 months, and Ndidi has been here for 4 months. So new to the Stanford system and new to the Bay Area. So we're very interested in hearing also your observations of what you're seeing in your department. Our objectives are that we want to share our background and the Chief Health Equity Officer role, define and describe health equity efforts broadly, and inquire about health equity opportunities for OHNS and other things that you've observed in the healthcare system. So our background, this is me. Please call me Nazleen. I grew up in West Windsor, New Jersey, Chief Health Equity Officer at Stanford Healthcare. I'm also an internal medicine primary care doctor and will be practicing at SIM. My interests include being in nature, especially around bodies of water, so very happy to be in the Bay Area after being in Cleveland. All things arts and entertainment, traveling, eating new foods. LaCroix lime water is my go-to, binging TV shows, and spending some quality time with my family. My family includes these individuals right here, my husband Rob, and my two children, Zayn and Zara. And anyone who's done Strength Finders, my strengths, I would say, are connectedness, achiever, input, learner, and individualization. And my background, as I shared, grounded in being a clinician first and foremost, especially around continuity of care. My training was at Harvard Medical School and Brigham and Women's Hospital, and then I ended up coming to UCLA, where I did a Robert Wood Johnson Clinical Scholars Fellowship focused on community-based participatory research, mixed methods, where I was basically a health disparities researcher and ended up getting a PhD in health policy and management. After describing disparities for many years, I got interested in intervening. We also ended up having our two children in California, but all of our family lives on the East Coast. So I ended up moving to the East Coast, where I worked at RAND, which is a think tank, and then ended up becoming the Director of Science and Policy at the Office of Surgeon General under our current Surgeon General, his first term, Vivek Murthy, and I stayed for 5 years in 2 administrations. And in that role, you got to see what people were doing around concepts like population health and the Affordable Care Act and how people were going from coverage to care. A really exciting opportunity to recognize the impact of policy on many of the things affecting our individual and population health. I then moved to Cleveland, Ohio, where I was most recently from, where I was the Associate Chief for Community Health and Partnerships at Cleveland Clinic. That meant that I was responsible for a proactive, outcomes-focused, community-based strategy for all of our work, a community health strategy for the entire enterprise, really focused on Northeast Ohio. And then, because I didn't get enough school, I ended up, but really, I was just more interested in how do you get things to be more sustainable, especially when it comes to interventions around health disparities and addressing health equity. And so ended up most recently getting a MBA at Yale in the School of Management. There's this wonderful fellowship supported by the Commonwealth Fund for those who are interested in the intersection between business and public health and health equity. So check it out or ask me about it afterwards.
All right, and a little bit about me. Also, please call me Ndidi. It's really lovely to see all of you this morning. Thank you for the invitation. I am actually from Los Angeles, California, born and raised, daughter of Nigerian immigrants. Oldest kid of 5, so never a dull moment in our family. And then I moved here by myself, but I am the aunt of 2 beautiful nieces, Ure and Muna. Muna just turned 3 on Friday, so she is a 3-nager, and she's a lot. And then things that I enjoy doing, I love good food, reading, sports, music, travel, and being physically active. So a little bit about my journey. After graduating high school, I went to the University of Oregon, go Ducks. I actually played basketball there during my time there. And then I traveled to the Midwest to attend medical school at the University of Michigan, and then went to Cincinnati Children's Hospital for my pediatric residency. Stayed there to complete a chief residency, and right after that year, joined the faculty and also joined as an associate program director for the pediatric residency and was in that role for 10 years. During my time there, I had several other leadership roles, was an operations leader as a part of our operational excellence structure, and then did a lot of community and population health work. Most recently, I was the medical director of our Pediatric Accountable Care Organization, which really was accountable for about 100,000 Medicaid covered lives in the eight Southwest Ohio County region. We also launched several health equity focused learning networks, including one that we call the Cincinnati Children's Health Equity Network, which includes 17 clinical teams, all working towards closing equity gaps. Our global aim was to essentially eliminate equity gaps based on race, ethnicity, and socioeconomic status. And so our roles as CHEOs, just wanted to give you all a little bit of insight into what we are accountable for. So our hope is to establish health equity as a strategic priority, both at SHC and SMCH. We really want to be collaborative leaders and develop a culture that promotes adopting an equity lens across the care delivery system. We want to foster an internal focus on eliminating healthcare disparities while building key community partnerships to support the work. We want to foster greater linkages between our clinical and academic missions. And finally, we want to work within interprofessional teams to develop strategic priorities and define key measures of success. So want to start off by just highlighting the why for this work. So many of you are familiar with the Sentinel report published by the Institute of Medicine entitled Crossing the Quality Chasm. And this report was really important in identifying that the care we deliver to our patients is not the care that they should receive. And this report called for the fundamental redesign of our healthcare delivery system to close the quality gap. And the committee proposed 6 aims for improvement. They noted that healthcare should be safe, effective, timely, efficient, patient-centered, and equitable. And even though this report was published over 20 years ago, we continue to miss the mark on equity.
Just to get back to basics about our definition, what is health equity? So it is the fair and just opportunity for everyone to be as healthy as possible through the process of removing obstacles to health. This is from the Robert Wood Johnson Foundation, which has been a leader in describing and advancing health equity. And this pictogram really sort of talks about this. What we tend to do in healthcare and medicine is sort of a one-size-fits-all, especially around our quality intervention. So that pictogram on the top, you can see everyone has the same size bike to allow everyone to ride. And equity is really tailoring that to what we do already in medicine. You know, see the patient in front of us and tailor the care plan to where they're at and what they need so that everyone has the ability to ride. Also, why do we care about equity? So as many of you know, the United States spends more than any other developed country on healthcare and continues to have some of the poorest health outcomes on life expectancy, infant mortality, and a number of diseases. This is from Betsy Bradley, who really described this paradox that we see in healthcare in developing countries. And what this graph shows is a number of the developed countries in the world. You can see that on the x-axis, and the amount that they spend on healthcare versus social care. Things like paid paternal leave, early childhood education. So in the most countries spend 2/3 on social care and 1/3 on medical care. The United States is the opposite. And so this has led overall to a country where we don't see the best health outcomes for everyone. Having said that, I would also argue that the United States has been a huge leader in innovations in medicine and in healthcare with breakthroughs in medications and technologies which have global impact, but we should also recognize what is happening to our own population and why that's happening. The other reason we care about health equity, quite frankly, is that there are a lot of emerging requirements for healthcare systems, whether that come from CMS and making sure that we screen all inpatients for health-related social needs, which we'll talk about in a second, whether that comes from Joint Commission, or whether that comes from California, which is now asking every acute care hospital to list out how they're to provide a health equity report annually that will likely be publicly available and transparent across the healthcare system. I'm not going to go through each one of these emerging requirements, but want to just share with you, this is also a regulatory issue. And then finally, health inequities are harms. You cannot, if you are somebody that cares about quality, safety, and patient experience, if you don't address health inequities, you are actually might be causing harms and wasting money towards your patient outcomes. So what are health inequities? There are health outcomes that differ across groups due to unjust social and economic policies and practices. As mentioned, they impact our quality, safety, and patient experience. And quite frankly, morally, we really shouldn't be celebrating all of our innovations if a number of folks are left out of it or left behind. However, health equity is not just the absence of a harm or unjust health disparity, it's also the presence of systems that promote and preserve healing, opportunity, and justice, and what I would say is the reason we all came into medicine to begin with. And progress towards equity is a metric that we should track and have accountability for the same way that we monitor and intervene for infection control or hospital length of stay.
So I think we're going to transition now and talk a little bit about how do we actually advance health equity. And in order to do this, we have to have a multifaceted approach. We can't just focus on what we as individual providers or other members of our healthcare team are doing. We have to think about the interpersonal interactions we have with our patients and families. We have to think about institutional policies and practices and how we make equitable practices the default. We have to think about how we connect with community partners and organizations to take a multi-sector approach. And then we have to think about the policies that impact health and well-being across our population of interest. And so key considerations as we do this work will include the intrusion of bias in healthcare institutions, right? So much published literature on the ways in which implicit bias affects health outcomes. And so how do we leverage the benefit of standardization when appropriate? How do we think about eliminating race-based medicine in our practices? And then we have to think about social determinants of health and health-related social needs. So when we talk about social determinants of health, Nazleen will cover this in more detail, but, we want to think about, what are the conditions that might be influencing health outcomes? And then how do we identify health-related social needs that might be impacting our patients' outcomes as well? And then we need to think about community partnerships in health. So this is a nice visual where which I use to really think about the various levels of systemic oppression. And oppression can be, it can vary. We can talk about racism, sexism, homophobia, all of the things that oppress minoritized groups in our healthcare system. And so we have to think about the individual level. When I think about this, it's really implicit or unconscious bias and how that influences health outcomes. Again, we have to think about the interpersonal level. We have to think about what we're doing within our own institution as SHC and SMCH that might be perpetuating oppression of our patients and families in the system. And then we have to think about structural oppression. So again, what are the various policies and practices at play that we need to be advocates for to either advance health equity or really try and think about the ways in which we can advocate for other policies that might or advocate for policies going away or being revised that are hindering health equity.
So a lot of people talk about social determinants of health. So first, where is the research around this? And we'll talk about what it is. So first, this is just 2 decades of research, even more, that shows that 20% of a population's health is really determined by the medical care that receives. Usually that's defined as just only access to care and quality of care. So we can think about all the other things that are related to clinical care, including medication adherence, visits, all that stuff. But the other 80%, and this number varies anywhere between 60 to 80%, happens outside of the healthcare system. And that includes health behaviors, which are influenced by your ability to engage in those health behaviors, your physical environment, which we'll talk about in a bit, about including where you live, and then social and economic factors, including education, employment, community safety. These are often called the social determinants, social drivers of health. They're the conditions in which we're born, live, learn, work, play, worship, and age. And they're often considered the root causes of poor health outcomes. They are also shaped by a larger set of forces, including politics, economics, and social policies. So here are some of the domains that people talk about when they talk about the social drivers of health: education, access, and quality; healthcare and quality, including healthcare access; your neighborhood and your built environment; your social and community context; and economic stability. When we talk about social determinants of health, this diagram shows the interplay of levels, very similar to what Ndidi talked about in terms of a multifaceted approach. So that's at the community level, these underlying social and economic conditions that influence people's ability to be healthy. But how an individual person experiences this, they might experience this as hunger or lack of insurance, and that's often considered a social need. So an individual's non-medical, social, or economic circumstances that hinder their ability to stay healthy and to recover from illness. And both the person and the community are influenced, again, by these wider set of forces that are fundamental to these social inequities. Again, economics, politics, and social policies. So at the individual level, we often see these in our patient interactions. You might actually see this in EPIC. There is, like, within your Healthy Planet, where you can actually see these health-related social needs that patients can fill out on the outpatient setting, as well as are being screened for on the inpatient setting. And they're more than 6 domains, but they usually fall within these 6 domains. Do you have food access or food insecurity? Do you have access to transportation that's reliable? Are you dealing with housing instability? Do you have finances for financial security, for the ability to pay for your medications and not have to choose between medications, rent, and food? Do you have social connections? Because we know that social isolation has a huge impact on your health. Are you exposed to any community or intimate partner violence? And we've just talked about the screening. In general, screening, what happens if people are deemed positive, they are often referred to social work. In some areas of our healthcare system, we're trying to broaden that. And the opportunities are, let's say that you are somebody that a patient that you see identifies as having food insecurity because they answer 2 validated questions on the screen. What ends up happening is that they are often referred to an external resource, not something internal to our hospital, but an external resource that's an expert in this, often a food bank, or where that community organization then connects with the patient, or the patient connects with that organization to receive that unmet social need. The opportunities around this are an opportunity for us to have closed-loop communication, meaning, do we know that if we referred somebody, a social worker referred somebody to the food bank, that need was met or unmet? And then we also have recognized through research that the people who answer these questions are often the people who are the least likely to have a social need. So there are some opportunities for mitigating the bias around who is getting screened and how we are screening patients. Another important tenet of work around health equity is that place matters. People who do health equity work often use this phrase, your zip code has a greater influence on your health than your genetic code. So this is an example of a map that shows the life expectancy at birth for the U.S. Census over 5 years, and you can see the huge geographic variation. The areas that are more dark blue are places with higher life expectancy, and the areas that are red are areas with lower life expectancy. So even within our nation, we are seeing huge variations in health outcomes. And why does place affect your health so much? Much of the work around health equity is place-based. It's because it's linked to so many other factors, including what kind of air you're breathing, and are you around pollution, your natural environment, the built environment. Do you have trees around where you live? Do you have access to the internet? Your population connectivity environment. Are you around people that can help you? Are you around animals that can facilitate transmission of diseases? Your social and behavioral environment, and then your health policy environment, which I think we're going to see play out more over the next coming years. So we've talked about the role of bias and oppression. We've talked about social drivers of health. We've talked about the importance of place. And then the last tenet around health equity is the role of having community partnerships and community engagement. We are not experts in public health as a system. And so much of the work that we do has to be in partnership with organizations that have the trust and expertise of marginalized and underserved populations, as well as just the trust of communities. So what is community health? This is a definition from the CDC. It's a multi-sector and multidisciplinary collaborative enterprise that uses public health science, evidence-based strategies, and other approaches to engage and work with communities. So it's co-designed, you work together in a culturally appropriate manner to optimize the health and quality of all persons. And some important principles around community engagement are that we value the lived experience as expertise. So many of us have MDs or PhDs in whatever area we're in. This is the PhD in the streets. So recognizing that is equal value. Creating power dynamics are huge, so sharing power and creating sustainable community collaborations. Often what we see is someone gets research funding, they want to work with a community partner, they do that work, it lasts about anywhere between 1 to 5 years, and then they're out. That is not how you build sustainable community trust. That is not how you have community engagement and partnership. So we need to change how we think about that and not approach communities with an agenda, saying, hey, will you enroll in my clinical trial? Hey, will you enroll in my research study? But actually have those relationships beforehand and then co-design work together. One last principle around community health is that this idea of recognizing that hospital and healthcare systems are this thing called anchors. We do not move in times of economic crisis. We are here for the long term. We are not going to leave this area. And with that comes a huge responsibility. We can apply our economic and human capital for the mutual benefit for community and enterprise. And what that means is our role. We are a major employer. And so people who have jobs within this healthcare system, we are creating an opportunity for wealth building. And so who are we hiring within our healthcare system? And are we giving that opportunity equally? Thinking about, we have a huge supply chain as an anchor institution. Who are we getting our vendors from? There's this idea, 30%, just so you know, 30% of Stanford Medicine's supply chain comes from minority and women-owned vendors. And then with our investment dollars, are we investing that locally? How are we thinking about those investments and those funds in terms of the betterment for community health for all? Okay, so time to talk about sorry about the misprint hint. Time to talk about some opportunities in this department. So we know that there are health disparities within otolaryngology. So 80% worldwide of hearing loss is in underserved communities. Oftentimes with pediatric patients, that's preventable. With adult patients, we know that has to do with access and cost. The area where we see the most research actually is around head and neck cancer. We see variations in presentation by age and stage by race and ethnicity, socioeconomic status, insurance status, whether it's a rural, urban, or suburban patient, and then health literacy and primary language. And all of these variations leads to disparities in survival rate, regardless of what happens here in the clinical setting. We pulled this directly from your website for around health disparities research. This graph right on the bottom that shows nationally the difference in survival time between Black and white patients around head and neck cancer. And then the graphic on the right really talks about the impact of low socioeconomic status as a driver for differences in health outcomes. So whether that's difficulty affording insurance copayments for head and neck care, long wait times for medical appointments, difficulty taking the time off work for your head and neck care, environmental exposures, increased risk of smoking, lack of access to healthy foods, all leads to delays in head and neck cancer care and worse health outcomes. I could have used this slide for any condition, quite frankly, and that leads to worsened poverty due to poor health, loss of income, and increased medical expenditures.
And then I wanted to pull some pediatric data, and there were several articles that highlight the health inequities within pediatric otolaryngology. We know that Black patients are 3 to 4 times as likely to have sleep disordered breathing as white patients, and they often have more severe obstructive sleep apnea, even when we control for comorbidities. We know that socioeconomic status and overall social vulnerability is associated with a 60 to 65% decrease in the likelihood of attending an ENT referral. We know that there are long delays for publicly insured patients obtaining a sleep study for sleep disordered breathing compared to privately insured patients. One study on pediatric inpatient admissions noted that Black children were 50% more likely to have respiratory complications after a TNA than other patients, and these differences were relatively unchanged after they adjusted for age, gender, obstructive sleep apnea, obesity, sickle cell anemia, or asthma. We know that children in high poverty neighborhoods are more likely to receive tubes for chronic otitis media, and those in low poverty neighborhoods for recurrent acute otitis media. And we know that publicly insured children tend to receive evaluation for tubes at an older age and have higher rates of loss of change in insurance, resulting in increased time between consultation and surgery. So the question becomes, what do we do? So some guiding principles that Nazleen and I are really going to use to do this work in partnership with all of you is that first and foremost, we really want to build a culture of equity here where our words align with our actions. Second, we really need to center and co-produce with families with lived experience. I think this is critical if we really want to design interventions that we think will meet the needs of our patient population. Data transparency will also be key, so we need to have a thoughtful and well-designed measurement strategy. We have to function as one team. We can't do this work in silos. We can't do this work with our traditional delineations of departments versus service lines. We have to be one team because that's the way that our patients and families experience us. We have to have strong cross-sector relationships with community partners. And most importantly, we have to identify and advocate for policies that have a direct impact on health and well-being of children and adults. And so want to share some other key principles that we think are critical. I think in order to do this work, we have to have a shared purpose. We have to have shared outcomes, and we have to have an aim for everyone within the system. So how do we cultivate a highly engaged community with shared purpose, with a focus on unprecedented results directed towards common outcomes with a sense of urgency? I think, again, I mentioned measurement. So, that involves defining our population of interest and really thinking about how we measure that. So are we measuring health outcomes for our entire population, for specific subpopulations? How do we define what the numerator and denominator will be? right? So how are we defining our community? How many individuals have certain conditions or diagnoses of potential interest? And how do we think about needs, risks, and assets that vary across a population? And how do we operationally define key outcome measures? And then how do we segment our data to identify opportunities to intervene, right? I think this is where accurate data collection of race, ethnicity, language, sexual orientation and gender identity and other key diversity dimensions becomes key in order for us to really ensure that we are interpreting our data appropriately and figure out opportunities to improve. So this is just highlighting some work that we did at Cincinnati, and what you're seeing here is all-cause admissions to our children's hospital in Cincinnati per 1,000 children 0 to 18 years of age in the most populous county where the hospital sits, Hamilton County. You will not be able to read the names of all of the different neighborhoods on the left side of this chart, but what's most important is that you see that the rates vary by neighborhood, with the rates of hospitalizations being much higher in socioeconomically challenged neighborhoods compared to more affluent neighborhoods. The same pattern persists when we looked at data of children and their well-child visit completion rates for 0 to 15 months of age. And the same pattern persists when we looked at kindergarten readiness in the Cincinnati public schools. And so again, really highlighting the point that place matters. This is looking at data for children who were admitted to Cincinnati Children's for our 30 most common diagnoses. And what we did here is we wanted to see what was the number of fewer admissions per year if Black youth had the same admission rate as non-Black youth. And you can see how this varies across conditions. At the very top is asthma. And essentially this chart is indicating that Black youth would need to have nearly 400 fewer admissions for asthma per year to have the same admission rate as their counterparts. Other important things that we need to do this work is define or devise theory with key members of our system, which includes patients and families, right? So this is how we develop key drivers, or really what we need to achieve our aim. This theory can be iterative and evolve as the team learns, and we usually connect this to change concepts and interventions. We need to identify our scalable unit, right? The scalable unit might be patients, or it might be clinic, or it might be a neighborhood, depending on how we are choosing to do the work. And then we need to think about how we test interventions guided by prioritization, how do we document our learning, and how to review and revise our theory and prioritization based on what we learn. And so we wanted to end by having an opportunity to have a conversation with all of you. Number one, we really value your insights, reflections, and we're happy to answer any questions. We also posed a few questions for you. What are the biggest challenges and threats that we face as it relates to health equity here at Stanford Medicine? What challenges do you see our patients and families experiencing? What do you see as our most significant opportunities today for health equity, both within our healthcare system and beyond our healthcare system? And where should we focus or prioritize our efforts? And finally, what can we do in this role to help support the efforts that you all are working towards as a department? So again, thank you for allowing us to be here today, and we look forward to this conversation.
Oh, sorry. So, Ndidi, for both of you, thank you for the presentation. It's very enlightening. Since you moved here from Cincinnati, I'm curious, since Medi-Cal takes care of basically all children here, right, in the state of California, do you notice a big difference between the equity, health equity between the children of Ohio and California?
Yeah, it's such a good question. So I will tell you that trying to understand Medi-Cal here has been an enduring homework assignment of mine. So I will share a few differences that I notice. So at Cincinnati Children's, we were the only hospital in the area that actually admitted pediatric patients, period. So even though there are lots of community hospitals, none of them have pediatric beds. And that was a decision made by the city of Cincinnati over 45 years ago to consolidate all pediatric care at Cincinnati Children's. So we took care of everyone. So yes, we were a quaternary care hospital, but we were also the community hospital. So our percentage of Medicaid and CHIP patients was around 50%. It also meant that we had this advantage of really taking a population health lens to the work. And so I would say at SMCH, what I have heard is that our payer mix in terms of Medi-Cal versus private insurance is about 40-60, give or take. I think some of the differences that I notice here is that there's just more access issues here than I experienced back in Cincinnati. I think the model of how Medi-Cal is structured here is also very different. In Ohio, you have the Department of Ohio Medicaid. You have about 7 Medicaid MCOs, and families can sign up for any 7, regardless of what county they live in. One of them has about 70% of the market share. Here, everything is county-based. So it's just it's more complex. It's very different. I think particularly mental health supports for our Medi-Cal patients here is also very different in that most of that care happens at the county level and not at our hospital. So I'm just trying to learn as much as I can, but I am noting some distinctions, and I think there are challenges here, but in a lot of ways, California has really invested in Medi-Cal with the 1115 waiver, CalAIM, where they have community health workers, as well as they're creating contracts with various community partners to address health-related social needs like housing instability, financial instability, food insecurity, transportation insecurity. And so I think there's an opportunity for us to identify patients who would qualify for CalAIM and that we can get referred to that program, because I think they're so still learning, and would welcome any thoughts or feedback that you all have as it relates to some of the challenges that you all are experiencing with our Medi-Cal patient population.
I'll just say one thing quickly from the adult side. So also in the same journey to understand Medi-Cal, we came from the same state. And so just fascinating in terms of the access issues and who the Medicaid managed care organizations partner with for what kind of care, and how that often leaves out some patients for getting care here at SHC, unless you are seeing the only niche specialist that's here. And I can tell you that, in fact, that has huge impacts on how people access care. Then here, the emergency department becomes the only way to access care here, because you cannot access care by calling up and making an appointment, because you're left out of the system. So I think there's many opportunities for us to have that, but recognizing we might have to do that at the county level, as opposed to just going straight to the Medicaid MCO and having that conversation directly with them for our entire health system, is something different that we'll have to tackle here.
Just a quick comment. It seems like you're already aware of it, but I think on the adult side, a significant opportunity and challenge is around the interplay between social work and behavioral health. I think we have a very weak behavioral health system here, and I think that on the adult side, and I think that sucks in resources on the social work side. Like I've had many conversations in my clinic about patients who have like maybe a borderline behavioral health issue. And then the best we can come up with as a group is like social work involvement, and this is not the patient who needs a social worker, right? Like not even close. And so it's a sticky problem because it requires years of investment and growth. And I like that you already kind of nodded to that, but I just wanted to emphasize that behavioral health insufficiency, I think, pulls away resources on the social work side. So like, I'm hopeful that that will change in the coming years.
That's really helpful to note. I will also let you know, we met with San Mateo County Public Health and Health System, and they actually also, because all of this work is a regional issue. It's not just a Stanford healthcare system issue. It's something that's felt, I would say, probably across all health systems. But this particular issue about pulling away resources from social work, I would say this is actually mental health, which I know behavioral health is more than mental health. It's also substance use disorders, but mental health is actually one of their key pillars that they want to focus on for their region in this area, recognizing, just quite frankly, nationally, this is a huge issue that often does pull resources from other areas and time from other areas to address.
Yeah, and I think the only thing that I will say is, I think for far too long we have separated mental and behavioral health from physical health. And I think it's really problematic. And so until there is a concerted effort to really invest in the mental health and well-being of our population, I think we will still struggle. Nazleen and I got invited to join San Mateo County's committee on mental health. So I'm hoping again that because we very much understand the importance of taking a population health lens and we can be at the table, that we can start to think about solutions. But you're right, it's a long game. And there's not going to be immediate relief or solutions, but it's something that we have to work towards.
Whatever you find out should be shared back through the hospital side, through the clinic structural leadership, which you're probably already aware of. Like, doing it on the university side is great, but like, we need like the operational people to be like, hey, we don't have a full toolbox, but these are the tools that are at your disposal. And then that should be within every, like on the nursing side and physician side, like kind of the known thing in the clinic. That would help, I think.
Thank you. That's really helpful. I think that was also the intention of our roles being in the healthcare system, and to recognize the operational needs from that.
Thank you both for that inspiring overview and presentation. Speaking of mental health, I think one of the elephants in the room is just that we're all worried right now about what's going to happen with our healthcare system. And I wonder what you're doing to anticipate or protect the efforts that you're working so hard to promote.
Yeah, I really appreciate that question. And I think this is a conversation that we've been having over the past week and a half. I think with the change of administration, we can anticipate where the focus might be. I do think Medicaid funding could be in jeopardy. As you all know, Medicaid is jointly supported by federal dollars and state dollars. During the Trump administration, the first go around, there was lots of conversations about funding Medicaid through block grants. There was an attempt to tie Medicaid eligibility to work requirements. And so we might see more of that, but it's hard to tell. If there is decreased funding from the federal government, I think we will see that some of our patients might lose coverage, which could be problematic. I think we worry quite a bit about, what's going to happen to evidence-based practice in terms of, we know vaccinations are key to public health. And so with the proposed lead of HHS, we could see some significant changes there. I think our immigrant patient population as well may be fearful to seek care, and so we're really going to have to monitor utilization rates, and we might see patients who present to the emergency department in extremis because they are not seeking care in a timely manner. So we've been having some conversations with our government relations team thinking about the ways in which we do this work and anticipate the challenges that might come and figure out how we could just continue to advocate for our patients and families as best as we can.
There are a few things in government that are statutes. So first, agree with everything that Ndidi has said, first and foremost. And we're talking about policy here and the levers that the federal government has on policy. I would say, I just want to, we want to talk about DEI and health equity. I think it's worth having this conversation. People often inflate these terms, and there's definitely a Venn diagram on them. DEI, as you have probably noticed, diversity, equity, inclusion, which often is internal. It's recognizing having your workforce and and that pipeline look very similar to the patient population that you're seeing. So it's real, and thinking about career advancing measures internal to your organization. It doesn't have to be a healthcare organization, it can be any organization. So we've definitely seen that under attack. And there will be some sort of adjustment made on that. Health equity, I want to just emphasize, is work that happens. It's things that affect our patients external to the medical care that we provide that is now leading to differences in health outcomes, even if we're giving the same exact care. So that is what that's about. And so I don't see that necessarily changing, but because these terms get conflated, there might be some thought around that. CMS did a demonstration project called Accountable Healthy Communities, and they just released their things. And what that was screening for these health-related social needs, food insecurity, transportation insecurity, housing insecurity, the things that financial instability, screening for that, and then connecting patients to resources. What they found was, after this large national demonstration project, that we saved about 3 to 6%, which doesn't seem a lot, but it is quite a bit, considering how much we spend GDP on healthcare. 3 to 6% reduction in Medicare and Medicaid beneficiary spend, and improved health outcomes. That was that just came out. That was huge to show that doing the work, recognizing that people enter the healthcare system, and we have an opportunity to do that kind of screening and then connect them to the appropriate resources, that probably won't go away. That is a CMS requirement. Also, there are regulatory requirements. In California, we talked about acute care hospitals now have to annually produce a health equity report with measures that are determined by HCAI. So that is already determined, and that will probably happen. And then we've talked a lot about the governor. I think what that's top of mind to me is that people will distrust institutions even more than they do now. And that is a long game if you are paying attention to politics, to have the majority of a population now question whether people are using science and evidence-based structures and how we feel about our institutions. And this is also an institution, please recognize, just not only the federal government, but the healthcare institution, which often nurses and doctors are often the most trusted individuals when it comes to providing health and science information.
Yeah, I just want to say thank you for this. This is excellent, and it's always good for us to consider these types of things. To Dr. Orloff's point, I work with the LGBTQ plus community quite a bit, and they're obviously very acutely impacted by this. And I will say that they've had the opportunity, we really at Stanford have had the opportunity to build up a system in the past 5 to 10 years that was really like a ground up design, which I think is an excellent model for exactly what Dr. Pepper was saying, which is that it was built with the social support, primary care, mental health, behavioral health resources in place, which is really the only thing that allows me to do the surgeries that I do, because I could not operate with patients without them having those support structures in place. I don't think that's exclusive to what I do. I think that's true of all of us, and we all see it. We may not think about it with some of the more routine surgeries that we do, but I wanted to go back to one of the things that you mentioned about with research, because I think that's one of our big charges here, and it's really one of the areas that we can make an impact in this. And I think when we think about research funding and duration of funding, and you talked about obviously not going to the communities, whether or not you consider taking advantage of patients to participate in research and then sort of abandoning patients afterwards. But is there a way that we can sort of incorporate our research, either collaborating with other individuals who can carry the banner after we complete the research, or are there internal resources that can look at your research and say, here's how you can make this sustainable? Because I think the fact of the matter is that as individuals, we don't have the resources to carry forward those types of things in the small, division or department that we're in.
Oh, I love this question. I think, there's a lot of anecdotal evidence to suggest that, we published, evidence-based research, but it doesn't really become part of our practice for 10 to 20 years, right? And I do think there is such a need to link our researchers with our operations team, such that as you all identify trends or interventions that work, we can then think about how we actually bring that from the bench to the bedside to the curbside. I think there's a lot of work to be done in that space. I think one of the vulnerabilities we have is that not all the work we're doing in this space, and when I say work, I mean research, operations, quality improvement, community engagement, not all of it is visible. And so when that happens, we run the risk of being duplicative or redundant in our efforts. We run the risk of not identifying things that really work. And so I don't have a great answer, but I think it's something that is top of our minds to try and figure out how we do that well and create opportunities for shared learning across the enterprise.
Yeah, just a few principles. Usually when people are talking about research, they're talking about enrolling Black and brown patients to get diversity in trials. That's what I have heard across the board, quite frankly, and that is a good thing. We want things to be representative. I think the challenge, what we can do in our roles, and I would love to hear what other people think too, what we can do in our roles is link people who do sort of that community-based research, who have those relationships already, and have sort of that ear on the ground of what's happening. And by the way, those people there is a huge network within Stanford Medicine, a wonderful network of people who have been doing this for decades to connect them. And we also have a Clinical Translational Science Institute, CTSI here, that's part of their mission as well. So I think our role can be connecting that, because you're right, you don't have, just like we talked about, not everyone has the expertise, not everyone has the resources. I also think it's incumbent upon us, and this is the longer game, to actually be in those communities. So to have folks from the hospital deployed in geographic areas to sort of build out our proactive strategy, where we are listening first and foremost, listening to the federally qualified health centers, listening to the State Department, listening to the schools, listening to the employers, listening to underserved communities and those sort of grassroots organizations about what their needs are, whether or not we agree, and seeing where Stanford could play a role. And then taking that time to build that trust. So when somebody approaches with an idea, even for a research or a clinical trial, it is co-designed. Right from the beginning, you can say, hey, this is something that we're going to go for this funding. Is there anybody in your community that has been impacted by this, that would care about this? You get that input right when you're writing for the study. Not as an afterthought, got the money, now, oh my gosh, how am I going to enroll all these patients? That's part of the criteria. That's the long game, though. So so we have to change our norm. And this is not just Stanford, this is just research in general, to think about, to go to a group of people that in general may have distrusted, we have not been good partners for research, and now how do we think about how to be better partners? So, listening first and foremost, and then co-designing, and then implementing. Yeah. Oftentimes our mentor, Joyce Saki, who we both report up to, we didn't talk about our reporting structure, by the way. I report to the Chief Medical Officer, Nirad Sehgal. Ndidi reports up to the Chief Quality Officer, Grace Lee. And then we both report to Joyce Saki. She often talks about trustworthiness. So, can Stanford Medicine be a trustworthy partner?
Well, thank you all for having us. Please don't hesitate to email us. We can make sure that our contact information goes out to the entire group. We'd be happy to come back and chat more. If you have other ideas or reflections, please send them our way. And we look forward to getting to know and working with all of you. Thank you.
Thank you.